Hello, my name is Mark Brockman. I'm a professor at Simon Fraser University, and on behalf of myself and all of my co-authors, I thank you for the opportunity to present our work today entitled Weak Humoral Immune Reactivity among Residents of Long-Term Care Facilities following one dose of COVID-19 mRNA vaccine BNT162b2, otherwise known as the Pfizer-BioNTech vaccine. Over the past year, we've learned a lot about SARS-CoV-2 viral infection, pathogenesis, and the underlying mechanisms of severe COVID-19 disease. One of the most striking observations is really the profound dependence or relation to older age and disease outcome. That's reflected by this data presented from the US Centers for Disease Control, showing a nearly 100-fold increased risk of hospitalization and a nearly 9,000-fold increased risk of death following SARS-CoV-2 infection among adults aged 85 years and older. And in Canada and elsewhere around the world, this has really been reflected in the impact of SARS-CoV-2 infections in long-term care facilities, where we're housing these more elderly individuals, often individuals who have other underlying health concerns, numerous comorbidities, for instance, including cardiovascular disease and other comorbidities. We also know from a number of studies that immune function declines with increased age, and so immune dysfunction may also be an underlying contributor to severe COVID-19 outcomes. We know that as individuals increase in age, at some point immune deficiencies and immune dysfunctions begin to predominate. This is reflected by increased rates of infections and risk of cancers among older adults compared to younger adults. In the context of vaccination, we know that older adults tend to mount weaker responses to vaccines, oftentimes needing to receive more frequent booster inoculations in order to maintain robust immune responses to vaccine antigens. So we anticipate in the context of COVID-19 that older individuals will display perhaps an impaired response to the new vaccines, including the RNA-based vaccines like Pfizer, BioNTech, and Moderna. But relatively few studies have directly assessed or addressed this question. So to do so, we've established a cohort in Vancouver of about 150 individuals that includes about 2/3 younger, otherwise healthy adults recruited from healthcare facilities, and about 1/3 of individuals that are older adults recruited from long-term care facilities or seniors living in the community. For today's presentation, I'm just going to focus on the earliest analysis of our first cohort of individuals that included 12 elderly residents of long-term care facilities and 22 healthcare workers, where we've assessed the antibody responses following the first dose of the Pfizer and BioNTech mRNA vaccine. So description of the participants are indicated here. Again, 12 long-term care residents. They have a median age of 82, 22 healthcare workers, of which 18 were seronegative and 4 had prior evidence of COVID-19 infection. So all individuals were recruited at the end of 2020 through early 2021. Serum and plasma were collected at baseline upon study entry, and again at 30 days following the first vaccine dose. In order to assess the antibody responses, we've looked at used a number of different assays to assess the presence of binding antibodies, to assess potential ability to block spike protein engagement with the ACE2 cellular receptor, as well as neutralization assays using both pseudoviruses as well as native SARS-CoV-2 strains conducted in our level 3 facility. So by looking at binding antibodies, we get the broadest view of the breadth or the magnitude of the immune responses. And then by looking at ACE2 competition and neutralization activity, we begin to hone in on the subset of the antibodies that are likely to be most important in terms of protecting an individual from infection or reinfection. So first, to highlight some of the results from our study, first looking at the binding antibody activities. So again, to remind you, none of the seronegative individuals displayed any evidence of a specific antibody prior to vaccination, so that data is not shown here. But following one dose of vaccine, otherwise the younger adults, healthcare workers shown in blue, or the older adults, long-term care residents shown in orange. Most individuals were able to mount a binding antibody response. One long-term care resident appeared to not elicit any binding response to one dose of antibody, which might be concerning. But among the others, we saw that the healthcare workers, the younger adults, displayed a significantly higher magnitude of binding antibody responses to spike compared to long-term care residents. Numbers are shown here on the right, but this amounted to about a 4.5-fold reduction in binding antibody among the elderly residents in long-term care facilities, which we think is a quite profound difference between these two groups. Among the convalescent individuals, all 4 of them displayed some evidence of spike-specific antibodies prior to the vaccine, and following one dose of vaccine, all 4 of these individuals mounted very robust binding antibody responses that actually exceeded the upper limit of quantitation for this particular binding assay. To look at the subset of the antibody responses that might block viral infection, we conducted ACE2 competition assays. Again, similar to the binding antibody results, the younger adults, healthcare workers, displayed better ability to block spike protein engagement with the ACE2 receptor compared to the older residents in long-term care facilities. This resulted in about a 3.5-fold difference between groups. The convalescent individuals also displayed some evidence of the ability to block ACE2 engagement prior to vaccination, as well as following one dose of vaccine. Moving on to pseudovirus neutralization assays shown here in the middle panel, again, consistent with the ACE2 competition data, as well as the binding antibody data. The healthcare workers, the younger adults, displayed better ability to neutralize pseudoviruses containing the full-length SARS-CoV-2 spike protein compared to the long-term care residents. Again, this difference was statistically significant. And perhaps most importantly, the ability to block native SARS-CoV-2 infection. So in this particular assay, there's a very robust assay that we saw actually very little evidence of neutralization activity in any of the vaccinated individuals following one dose of vaccine. At the lowest dilution of plasma that was tested of 1 to 20 dilution, 6 out of the 18 healthcare workers displayed some evidence of neutralization, whereas 1 out of 12 long-term care residents displayed some evidence of neutralization, again, of live whole SARS-CoV-2 virus at this low dilution, none of which we think is probably going to be protective in vivo. But still reflecting that the healthcare workers did mount a somewhat better response compared to the elderly residents of long-term care facilities. Notably, the 4 convalescent individuals, their plasma had no evidence of virus neutralization activity in this assay prior to vaccination. However, at 30 days following vaccination, all 4 of them mounted very robust and neutralizing antibody responses to this native SARS-CoV-2 strain. Suggesting that there was quite good memory responses that could be elicited quite quickly following infection in these 4 individuals, which is also something to consider in the future. So we continue to enroll more individuals in this cohort, and we continue to look at the responses following 1 and now 2 doses of vaccine. So it's just a summary of where we're at in terms of looking at binding antibody responses in this population. We continue to see, even with more data, that the long-term care residents, the elderly population, is mounting significantly weaker binding antibody responses following 1 dose. There's even now some evidence that following the 2nd dose, they remain somewhat lower compared to the otherwise healthy younger adults. Though these values are now starting to get up into the range where you expect they would be reflective of some sort of protective activity. We've also looked at additional individuals who had prior evidence of COVID-19 infection, both younger adults as well as older adults, and we've seen consistently that one dose of vaccine is able to really boost binding antibody responses in these individuals. The additional ACE2 competition assay and viral neutralization assays are currently ongoing. So just in closing, there are a number of limitations of this particular study, and certainly it was small, including only 12 long-term care residents, but the results we think are still quite striking and statistically significant despite the small numbers. It's still unclear what the implications are of in vitro assays for binding and viral neutralization for in vivo situations of transmission and disease progression. Epidemiologic data from the US CDC and elsewhere suggests that one dose of the Pfizer vaccine is associated with a reduced risk of hospitalization of about 64% among older adults age 65 or above, whereas 2 doses of the vaccine are associated with a reduction of about 94% in terms of hospitalization. We think this is in keeping with the antibody responses we're seeing for binding and neutralization in our assays, but we can't make a direct link between the two. Certainly correlates of vaccine protection have not yet been identified and validated, and other immune responses that we haven't measured in this study are likely to contribute to disease outcome in individuals. It could be T cells, it could also be non-neutralizing activity of antibodies that we have not tested. Finally, we have not assessed SARS-CoV-2 variants of concern in this study, and that work is ongoing. But just in terms of summary, we've observed humoral immune responses elicited by one dose of this Pfizer mRNA vaccine were significantly weaker among elderly residents of long-term care facilities compared to younger healthcare workers. Partial immunity that we've observed in residents and even some staff of the long-term care facilities after one dose of vaccine may pose new risk for outbreaks in long-term facilities or long-term care facilities or other healthcare facilities. And indeed, we've seen some evidence of outbreaks following vaccination in Vancouver area facilities. And finally, we think that our data provide a bit of a cautionary tale for seniors living in the community that may also remain at elevated risk of infection, in part because they are only partially protected against infection, but also because a majority of their contacts in the community may either be unvaccinated or display only partial protection themselves. So with that, I'd like to thank our funders of the COVID-19 Immunity Task Force, also thank all of our participants for their contributions to the study, as well as all my colleagues at Simon Fraser University, University of British Columbia, Providence Healthcare, and the British Columbia Center for Excellence in HIV for their contributions to the study. And with that, I'd be happy to take any questions. Thank you.